Welcome back to the American College of Surgeons Bulletin Brief from the Frontline Surgeons' Voices. With me today is Dr. Heidi Nelson, who's been a guest during prior interviews. Dr. Nelson is, of course, the director of the cancer programs for the American College of Surgeons. Welcome, Dr. Nelson.
Thank you for having me, Steve. Good to be with you.
Always a pleasure to speak with you, although normally it would be in person at least 4 or 5 times a year at various college activities, and now it's on a virtual basis. And that might be the starting point of our questions. One of the other activities since you and I last chatted during an interview is the onset and the continuation of virtual site visits for the cancer programs. And perhaps you could tell us a little bit about how those visits have gone and what your plans are for the continuation or discontinuation of virtual visits as the pandemic hopefully quiets down.
That's been a remarkable journey. And I want to say a moment of gratitude for the people who piloted the experience and helped us develop the parameters, both on the staff side, on the surveyor side, and on the institutional side, because it's taken off really well. We've done over 130 site visits virtually. We have 400 between now and June. And so it's remarkable how well that's gone and how quickly people were adaptable to doing it virtually. And the technology supports it pretty well. There's still a little bit of a challenge sometimes with really the richness of the conversation. It used to be the little sidebars when you went to get coffee during the break or during lunch. You would have those one-off conversations with a site visitor. But I would say that our surveyors have really figured out how to do that in the absence of those little moments. They work the room by inviting each person who's attending to participate with a comment, and they may have a specific question for them. So humans are very resilient and adaptive, and that's really shown to be true with virtual site visits. Whether we'll keep them as they are going forward and say why have the travel and the hassle and all that, yet to be figured out. I don't know whether there's too much missing or we really feel like it's more than sufficient. So I don't have the answer to that. I don't think anybody does, but right now it's working well, and I'm just grateful for that.
Thank you. So at least through June, we're scheduled for virtual visits and then to be determined thereafter. One of the other uses of video has been on a local level for the multidisciplinary conferences. We certainly employ them for the National Accreditation Program for Rectal Cancer, NABPC, and others. And I've heard comments from people that it's much easier to attend because they don't have to go across campus or maybe between hospitals to attend. Do you envision that after the pandemic, virtual participation in MDT would still be allowed? So in other words, whether the site visit is in person or virtual, the site surveyor might look at the roster and say, okay, in person were these 15 people and by virtual participation were these 35. Do you imagine that might be permissible?
Yes, I do. I think what I've heard, similar to what you've heard, is it increases the ability of people to participate, number one, because if you have a long travel time, and certainly in rural America, there's a lot of that, and across networks where there's people at different sites, it really enables good, strong attendance. The other thing is it has flattened the world a little bit. So historically, if the things were done virtually, but they were hybrid. So there were 10 people in the room and the rest called in. They weren't given sort of full citizenship, if I can say that. Whereas now everybody's virtual. So everybody feels like their voice is kind of equivalent and they get heard. So that may not be universal, but that certainly is a benefit that I've heard of, is that everybody who attends by the video conferencing technology shows up the same way as everybody else does. And that's an interesting benefit. And I think that's great. And I think they'll continue to be virtual because the inconvenience of the travel is probably high enough that people would rather just be able to do it virtually. But I think you know, we still like in-person things. Our conversation's great here, Steve, but I wouldn't mind being across the table with you having a meal, or on a walk, or whatever it is at a meeting in the breaks. It stimulates us to think differently and allows us to have a more bond building experience, truthfully. So we'll see where that goes.
Another potential use, which has become a very real use relative to, as you mentioned, inconvenience of travel, is telehealth for patients. And for cancer patients, contingent upon the type of cancer, they may not have people in their immediate geographic area who have significant expertise in that type of cancer. They may ultimately make a decision to stay locally for treatment, but want counsel from others. And where have you seen telehealth going for cancer patients during this pandemic?
I am under the impression that telehealth has been remarkably beneficial for reducing the sort of in-person footprint of the patient in the hospital or in the clinic when that's really not necessary. Whether it's asking them a few questions about something, maybe it's a preoperative visit is done, perhaps telehealth, maybe a follow-up visit for an oncology doctor where, most of the time you don't need a physical exam. You might be able to get enough information from looking at them on a screen as to whether they look like their usual cells. So I think I believe in clinical trials, they sort of, allowed more of that as well to, if you're consenting somebody, maybe it can be virtually. So again, I think we'll have to do an assessment and say, did we feel like we achieved the same level of communication and that we need when we're working patient to provider? And I think people will have a pretty good opinion of that once the opportunity to go back to in-person comes. Plus, there'll have to be some changes in insurance coverage and regulatory and things like that.
As we relate, just before we leave the topic of telecommunication and video, do you imagine that the 2021 cancer meetings, the educational meetings that we would normally hold, are going to be in person or virtual or hybrid?
Yeah, my crystal ball doesn't go out quite that far, unfortunately, because I had kind of hoped that by July there would be enough vaccination and enough herd immunity that the restrictions would come down and people would feel safe to travel, and institutions would allow their people to travel. Based on what I'm seeing in the news still about hospitals and providers being pretty stressed, and what I see about the vaccine not getting as widely disseminated as had been planned, or as quickly as had been planned, I'm kind of pushing my projections out, and I'm not sure we'll be quite ready for in-person by July or August. And certainly under the college, I wouldn't even venture a guess as to whether it's going to be safe. And it'll also depend on what the institutions decide to do with travel with their providers. Again, they've been, depending on where you live and how your community has been hit by COVID, we hear about a lot of stress on providers. And so there'll be a lot of factors that go into whether when and how we resume meetings.
Speaking of meetings, the Commission on Cancer started meeting almost 100 years ago. So we are soon going to embark upon a huge landmark event, our centenary of the CoC. Maybe you can give us a glimpse into some of your reflections about the significance of that centenary, as well as any plans you might want to let us peek under the hood and reveal to us.
Yeah, no, I'm enjoying the opportunity to look at the material that Connie Burra and others have brought out of the archives of the college, to start probing them. I mean, I've been part of the cancer programs off and on, since the early 1990s. And so I've seen progress and change, but it's not till you go back to the beginning and see some of the early manuals for cancer care accreditation that you realize that the founding fathers really set a remarkable course and really understood the keystones, if you will, of what it takes to deliver good care. Because truly, they had a committee on cancer, back in the 30s, cancer registry, and cancer consultative services that require documentation. You have to put in the record what you did with this cancer patient, and then you keep that in a registry, which was in the hospital, the tumor registry, with abstracts. And so it was, when you think about it, Steve, we're still doing that, only we're modernizing it. So they put in really effective foundation that we're building on, and what we're doing is just bringing it into the modern age. We're bringing it now into the information age, the digital age, where we have EMRs and where information is data, and data becomes the rich source of quality, the rich source of research, the foundation for future treatments and new knowledge. So I am amazed. Probably I shouldn't be surprised. They were brilliant people. They set a really solid course.
And I think that course has been continued. It's certainly during the last couple of decades as we've continued to add more programs. I mean, the CoC is 99 years old. The NCDB, if memory serves correct, was the brainchild of your predecessor, David Winchester, 40 odd years ago, something more or less, started that program, which is now the world's largest repository of cancer cases, to my knowledge. More recently, there's been the NAPRC, and then under your watch, very recently, the Cancer Standards Programs. What's on the horizon? What's next? We've increased the offerings within the cancer division of the college. What's next?
Yeah, that's a good question. Part of it is the modernization of the tools. Like, it used to be a tumor registry in the hospital, and then it became the National Cancer Database, where you aggregate the data into a single large repository, as you said. And now we're with the new rollout of the rapid cancer reporting system. It has the capabilities, and it's already starting to show it can support quality. And there's a greater linkage now between the quality of care right now with the long-term outcomes. If you only looked at 5-year or 10-year survival and you say, well, we're not doing that well in ovarian cancer, you just have to ask yourself, well, what could we do different? It would be pretty hard to understand, because you have to think back 5 years to what were you doing 5 years ago. And so as we start to make the link between early events in first treatment, for example, diagnosis or treatment, and long-term outcomes, we can now start to change the course of cancer outcomes. And that's a very important step. And that requires us to start linking data together and programs together. It also means having the data go into the database quickly, as soon as possible. And we can do that now. The barriers to technical acquisition right away of data is taken down. So people can put the data in right away, which means you can get your reports right away. Tells you whether or not you're doing well or you have some gaps to close. And we're also putting in place curriculum for quality improvement and quality measures that can help people sort of understand how continuous improvement right here, right now, impacts the long-term survival of these patients. So everybody ends up with better care. So it's a lot of, again, modernization into the information age. We're standardizing. We have, as you know, the operative standards are brand new. And the synoptic operative reports will be a digital template that supports those standards and allows a clinician to hopefully within a couple of minutes click on it and have it done. And that data is that becomes data. That becomes not just narrative information, that's hard to interpret and maybe missing a lot of detail, which it often is, to here's the facts you need to know. And that's really goes back to what the founder said, is you need to be clear, consistent, and provide information for all the providers now, including the patients, so they understand what really happened.
Very, very exciting. And under your inspirational leadership, I know that we're going to logarithmically accelerate our process forward with cancer programs. Any other parting thoughts for us before we conclude the interview?
Yeah, I want to bring up one other area that we're thinking about and really probing. It's part of the cancer research program. They've had a dissemination implementation committee for several years now. And that's a science that's starting to emerge because, as you're aware, there's a 17-year gap between research is being produced and practices changing. And you know this from laparoscopic colectomy work that you've done and the training you've done. And it's still not even probably much past 60% implementation. And it's been 2 decades. So what are we going to do about that? And I think the Commission on Cancer, NEPRC, NEPBC are great vehicles, because when you say it's time to adopt these things as standards, if you put them into an accreditation system and you give people the tools to get there, I think we can help reduce that 17 years and make sure that the hard labor of research turns into the beauty of better care for patients in a more expeditious manner. That's my goal, is the translation is something we can do something about.
Thanks very much. I appreciate your time and your wisdom, your insights, and especially your leadership of our cancer programs. It's always a pleasure to chat with you. And as you've said, and as I've said, hopefully soon in person again.
That'd be great. Looking forward to it. Thanks for your time.